So we are here for the next session now, after a wonderful uveitis session that just concluded. And we're going to talk about, Dr. Tenonang is here. So please join us in the chair. Okay, so this is angle closure glaucoma in the young, that is less than 40 years, which we have been seeing lately. A lot of them have been coming lately. So we just thought that we'll compile a session here. So first talk, I invite Professor Vinay Gupta, sir. He's a professor in RP Center, AIMS, and he's been my mentor, and a wonderful mentor at that. And he'll be talking about genetics of the angle closure glaucoma in the young.
Thank you, Shika. So basically this IC is because we have been seeing a lot of patients who have come to us at a very young age with angle closure. Some have come even as young as 10 years. So over the years, we have a huge series of such patients, including a large number of families. And so we have decided to conduct a genetic evaluation for these patients. So as we all know, it is uncommon, unlike the adult primary angle closures. And the pathomechanisms of this disease are very different from the adult onset angle closures. And there's already some evidence that the genes for inherited retinal dystrophies are commonly seen in these patients. So this was a cohort of about 72 patients out of almost 200 angle closure in the young that we had. And we excluded all the nanophthalmos, spherophakia, the secondary angle closures in this group. We took those patients who had high intraocular pressure with glaucomatous optic neuropathy, and we found that the primary mechanism of angle closure in these cases was either a plateau iris or a pseudo-plateau iris configuration. So there was something to the ciliary body that was not normal in these patients. And then we subjected them to whole exome sequencing, where we looked for primarily non-synonymous pathogenic variants. And we looked for primarily those associated with glaucoma and those associated with IRD in these patients. So the findings, we found that they were basically, these eyes had a smaller axial lens, the anterior chamber depth was also very shallow, and we did a cluster analysis to phenotypically categorize them into two groups, and we found that based on the biometric characteristics, there were two distinct groups where some of the eyes had very shallow anterior chambers, and this was the cluster 1, which had ACDs of almost an average of 1.9 millimeters and a thicker lens compared to another cluster. So this clustered analysis was primarily done so that we could then genotype and phenotype and provide some type of a correlation between the two. So the pathogenic or likely pathogenic variants that we found were almost 55% in these patients. In the rest of the patients, we could not find any variants of significance, and primarily most of them were IRD related. So there is something to do with the retinal problem here. And of course, there were some microphthalmia related variants in 2 patients, and glaucoma variants also found in 2 patients. But the retinal pathologies, then we started screening them for the retinal problems, and we only could find definitive retinal disorders in about 20% of these patients. So this is a large list of genes, primarily with IRD, that we found in our cohort of primary angle closure in the young. So there is one paper from China which has shown in about 31 patients, they looked at the genetic variants associated with PACGY, and they found some variants. Of course, we had a larger number, and we found a larger number of variants, and except for 2 genes which were common in both of the papers, we really did not find much similarities in the genes, but most of them in both the studies were related to IRDs. So the cluster analysis that we had done, we then genotyped them, and we could not really find a correlation between the genes and the phenotypic clusters that we had initially found between the 2Ds. So this is one case where a myo7A, which is associated with high myopia, was seen in a patient with early onset angle closure, and this is generally associated with high myopia, and this patient did have high myopia with angle closure. Best disease, mutation was also found in about 3 patients, and there was a classical macular dystrophy in these 3 patients, along with the angle closure that they presented with. Another case of a pathogenic BEST mutation in a patient where you can see that there is an advanced glaucomatous optic neuropathy. There was there were 2 patients who had a CRB1 mutation, and this is classically associated with the plateau iris syndrome and has a fenestrated macular dystrophy, which was also present in these patients. Then there is this RP1L1 mutation that was found in about 4 patients. These were all again pathogenic mutations, and this is characteristically associated with an occult macular dystrophy when at a very young age the retina looks normal, but over a period of time the worsening of the macular pathology happens. So this again was a case of a very young patient who had angle closure and presented to us, and it's only after we did a genetic analysis that we went on to do a retinal phenotyping. Another case with a similar kind of a picture, advanced glaucomas and a sheen in the macula, which is characteristic of the occult macular dystrophy. The CNGA3, which is associated with achromatopsia, was also found in about 3 patients, and this again is associated with more or less a normal fundus, but all of these patients had angle closure at a very young age. There was one patient who had a myocilin mutation, and we thought that probably, we had misdiagnosed the patient, but when we really looked at their AIOS2025-IC1011-Angle and their anterior segment characteristics, it was very characteristic of a plateau, of a pupillary block, and I mean, this was again a very surprising feature of a myocilin mutation presented as an angle closure. So there are a few studies where they have done biometric studies. There are some studies which have shown that there is an increased incidence of acute angle closure glaucoma in eyes with retinitis pigmentosa. There are a few case reports, including one from our center, where we have seen a higher incidence of X-linked retinoschisis with angle closure. But we didn't find any RS1 gene which is associated classically with X-linked retinoschisis in our cohort, but I do have seen a few patients with X-linked retinoschisis and angle closure. So it is present in a lot of patients. So some of the limitations are that we only looked for exonic variants. We did not look for copy number variants in our study, and we could not actually characterize all retinal dystrophies. Of course, the work is going on, and we're trying to develop a genotype-phenotype correlation to find out the IRD-related genes and the retinal pathologies that could be present with these. So to conclude, I would say that there is a high association of these with angle closure in the young, and of course our study has expanded the number of retinal genes that could be associated, but we need a more careful evaluation of these retinal dystrophies in our cohort of patients, and possibly there could be some association with the morphogenesis of the retina and that of the ciliary body that could be linked to the pathogenesis of both the conditions. So thank you.
I invite Dr. Tinong sir to tell us about your experience of genetics in angle closure glaucoma of the young. Yeah, you can see here. Not your talk, about what he's presented. What is your experience?
Oh, sorry.
Yeah. About your experience of genetics in the angle closure glaucoma of the young. What have you been
Right. Actually, we haven't really looked at this group of people, but I agree with Vinay that there's certainly some association with RP. Some people RP get angle closure glaucoma, so we don't know whether it's a primary or a secondary, and maybe it's due to the RP, some kind of a dystrophy. The morphology of the eye is a little bit different, and certainly there's some microphthalmia and all. Did you take out those with microphthalmia? Yeah. The other thing is that when you do a whole exome sequencing, I think it's very difficult because you don't know which variants are really pathogenic, and there's a lot of interpretation is not easy, especially when you're just looking at 72 cases. And I don't know how many controls you had, but it's not so easy to tell which are really pathogenic. So even on some of these variants, you may think that it's a myocilin variant, but it may not necessarily be
all pathogenic. The ones that we have were all graded as pathogenic.
Okay. So
myocilin.
Okay. Yeah, but even then, I mean, these are using software that predicts whether they are pathogenic or not. So, yeah, it remains to be determined whether they are truly pathogenic. And and whether they did run in the family as well, and maybe you need to look at the pedigree of those people with these variants to see if they run in the family to have better evidence of inheritance.
Yeah. So now I invite you to talk about your next talk in this session, Genetics of Angle Closure Glaucoma and Manophthalmos, the Singaporean context.
Thank you. So there's a lot of speakers didn't turn out, is it?
Yeah. So we have time.
Okay.
You can take your time.
Okay. Thank you. I'd like to thank Vinay for inviting me to give this talk. No relevant disclosures. I come from Singapore, and these are some pictures of Singapore for those who have not been. And I come from the Singapore National Eye Centre, which is the main eye hospital in Singapore. So one of the questions that my group has been working on is the genetics of glaucoma, and why is our interest in it. I think primarily we want to hope to understand disease biology and seeing how the genes are involved in the disease and maybe in pathways. We also hope to find some applications for personalized medicine. Maybe people carry certain changes or variants which make them at risk of severe glaucoma, or they may be helpful in screening or early detection. And also in the long term, we hope to develop new targets or therapies based on genetic findings and understanding the biology of the disease. And actually, we are looking at all forms of glaucoma, including open angle glaucoma, angle closure glaucoma, and exfoliation syndrome and exfoliation glaucoma. So main interest has been on angle closure glaucoma, and as you know, it's an important form of glaucoma in this part of the world. And for the last 20 years, I've been working on this question: is there a genetic basis for angle closure glaucoma? And as you know, there is different stages of the disease, from angle closure suspects to primary angle closure and primary angle closure glaucoma. And I think that what we're looking for is mostly genetic risk for the severe end of the spectrum of angle closure glaucoma. So when you look at glaucoma genetics or any disease genetics, there are some variants which run in the families, and perhaps they cause mutations which are inherited, and these are more rare or often Mendelian inheritance, and they are often associated with early onset disease, whereas the more complex or common glaucomas like we see in our clinic, like not the young people but the usually elderly groups, often may not have such strong mutations, but they may have genetic risk factors or genetic variants that increase risk for the disease. And usually these are associated with adult onset glaucoma, and these are, I would say them as genetic risk factors. So for example, in angle closure glaucoma, we do certainly see a higher prevalence of the disease among first-degree relatives or patients with angle closure glaucoma, and this has been described in many populations, whether it's in white people, Inuits, as well as in Indian and Chinese populations. There's a family history, it's an important risk factor, and it runs in higher risk in close family members. So for example, in siblings, you have a higher risk. If one of your siblings has angle closure glaucoma, you have almost 50% chance of having some form of narrow angles, and the sibling relative risk is almost 8 times greater than general population. And the Arabian group also found this in South India, where you have a very high risk of siblings having a higher risk of the disease when you have one proband affected. We've also seen angle closure pedigrees like this, and they also, you will probably, it's not common, but you may see in your practice, people who have angle closure glaucoma with a very strong familial basis, almost like a dominant inheritance. And the pedigree in the center was actually part of my PhD project, and I never actually found the gene for this pedigree, but you can see that it can run in many branches and many generations as well. But the UK group in Moorfields, they did find a gene for angle closure glaucoma in this 7th generation white pedigree with angle closure glaucoma, and they found this gene called SPARTA13, which seems to be the causative gene in this pedigree. So certainly there are some pedigrees where you have almost in Mendelian inheritance. So but the vast majority of patients that we see are complex inheritance, and so initially for more than 10 years, we've been looking at genetic risk factors by approach called genome-wide swing studies. So basically, this is a case control study in which you compare cases with controls, and you run variants of polymorphisms in between cases and controls, and you compare these, and typically you look for association signals to be associated with the disease. And in this approach, the p-value of significance is 5 times 10 power minus 10, and this is called the statistically significant for a GWAS study. And the plot that you can see is called a Manhattan plot, and this looks like the towers of Manhattan. So imagine this is buildings in Manhattan, and the taller the building, the stronger the signal. So if you see like a very tall signal, like in this picture, in the arrow is a significant association because it's above the value of 5 to the power minus 8. This is what a GWAS platform looks like. And a GWAS approach is usually finding genes associated with a disease. And as I said, it suggests some association, or possibly a biology or pathway. And it's very agnostic or hypothesis-free, so you don't know, you're just trying to see what you find. And the many genes that come out, you can see they are like alphabet soup because each gene has all these different letters. So when you have GWAS studies, you find lots of alphabets, and these each represent a genetic locus. So our group, in collaboration with the Worldwide Consortium, have done 2 large GWAS studies in 2012 and 2016. And for this GWAS study, you have to define the phenotype. And the phenotype we used was angle closure glaucoma with optic neuropathy. So you just didn't look at PACS or narrow angle. So they had to have glaucoma optic neuropathy. We also included patients with acute angle closure. And this is because if you leave acute angle closure untreated, they may get angle closure glaucoma over time. So it's a very severe phenotype. And so in the first study in 2012, we had multiple populations from Singapore, Hong Kong, Malaysia, India, and Vietnam in the first stage. In the replication, and again, multiple populations, including a British population, a Saudi population, and again, Indians and Chinese as well. And altogether, almost 4,000 cases and 18,000 controls were studied. And we found the first 3 genetic risk factors. You can see the odds ratios here on the column on the right in red is between 1.2 to 1.5, which means that if you have that genetic risk factor, you have 20% greater risk or 22% and 50%, etc. So these are GWAS signals, and one of them is very interesting. It's collagen 11A1 is a gene related to collagen. So that's also interesting for angle closure glaucoma. In 2016, we did a bigger GWAS, this time with 24 different countries involved. You can see that there was some involvement in the European and North American and South American populations, as well as Australians, and a lot from Asia. And in this bigger study, where we almost studied 8,000 people, we have found another 5 genetic risk factors. Here you can see the odds ratios between 1.15 to 1.24. And one of them is a very interesting gene, choline esterase acetyltransferase, which is involved in the neurotransmitter acetylcholine. So as you know, the choline system is important in angle closure glaucoma. We do treat people with pilocarpine, for example. So this is very interesting finding. And in fact, actually, the pedigree I showed you from the UK, that pedigree actually linked to the area where this gene resides. But we couldn't find the mutation in that pedigree. So it would be a brilliant story if we went back and found that mutation and also linked to this that big pedigree. Yeah. So it's a bit strange. Maybe we didn't do a good job with sequencing in those days. And again, collagen 11 as that came out. And there was also a GWAS for quantitative trait called anterior chamber depth. As you know, anterior chamber depth is a risk factor of angle closure glaucoma. And in this GWAS, in 2014, there was a gene called AIOS2025 associated with shallow anterior chamber depth. So from GWAS studies, you can see that there are 8 genetic risk factors identified and 1 for anterior chamber depth. But this probably only explains about less than 10% of genetic basis for angle closure glaucoma. And why is that so? I think because the sample size so far has been quite small. We only had about 10,000 people. So for example, for a POAG, you have almost 300 genetic loci found so far. And this is because the number of people genotypes close to 50,000. And so, you do have need more sample size to detect variants of smaller effect size. Another problem is perhaps the phenotypes. I told you earlier, we had an angle closure glaucoma phenotype. And you know that, as Vinay was saying, there are different subtypes of angle closure glaucoma. So there could be plateau iris, could be different from lens associated or pupil block. But because we have limited power, we lumped all our cases as angle closure glaucoma. So if you look at subphenotypes, you may find different genetic bases. But for that, you need power again. And as I said earlier, the sample size is very important because when you want to find odds ratios of smaller and smaller effect sizes, you need at least bigger and bigger sample sizes. So the other question that we were asked is whether this GWAS findings can explain racial differences in angle closure prevalence, for example, why more common in Asians, in Chinese, etc. But unfortunately, we couldn't answer this question because most of our cases were from East Asia. So there was not, we couldn't decipher out the non-Asians. For example, the white populations were very small numbers. But recently, Anthony Kawaja in the UK, he's did GWAS of European cases of angle closure, and so there's some overlap and some differences as well. So that is something which is hopefully going to be published very soon. And another thing is that some of the associations we found were only in Asians. So like plaque A7 and choline acerease was only found in Asians and not in other populations. Another question that was asked was, these genetic risk factors, are they a risk for angle closure, the narrow angle configuration, or is it related to risk for the glaucoma? So this is a very interesting question, and we try to look first at the gene expression. You can see that all the GWAS hits, the genes are actually expressed in the angle. So it doesn't really help you understand, is it the angle or is it the glaucoma? So I worked by Monisha here in the audience. She first, what we did was she wanted to see the angle closure glaucoma SNPs related to early angle closure of the PACS. And so if you think that if it's in PACS as well, it should be related to narrow angles. And so we did, in this study, we looked at whether the association was also in PACS, but we were very surprised that of the 8 angle closure genes, only 2 of them were associated with PACS. And the others 6 were not associated with PACS. So this was a little bit surprising. So it suggests that those 2, which is associated with PACS and PACG, it probably could be related to the narrow angle configuration. And for those that were negative for PACS, we don't know what that means. Perhaps they are associated with severity, or perhaps with progression, or maybe later stages of angle closure glaucoma. So it is not related to the narrow angles. And another question we asked was, is there any marker for severity? And we found that one of the 8 angle closure loci, EPDR1, was very strongly associated with more severe disease, particularly more glaucoma damage and high risk of severe glaucoma. Is that a alarm?
Yes, yes. Please carry on.
Actually, there are only 4 talks. So, another limitation of GWAS is that, as Binti was saying, many of these variants are actually intronic. So when you have intronic variants, we don't know what that means, how it affects the protein or the function of the gene. And so sometimes they could be a surrogate, and they may not necessarily be in that particular loci. So for example, in this work that we did for exfoliation, in one genetic locus, there's associated signal is in blue there, and there are 4 genes in the region. So any of the 4 could explain the signal. So sometimes GWAS studies may not really tell you which is the particular association. So the latest work we've done, as Vinny has done, is a whole exome sequencing. So in whole exome sequencing, you are doing sequencing of the exomic region, which is the coding region of the genome. And here, when you do whole exome sequencing to discover genes associated with disease, you're doing something called genetic-based burden analysis. So basically, you're going to count all the variants in cases compared to controls. And you use filters like Vinay was using, which will predict whether it is pathogenic or not. And so you put the pathogenic case variants and compare across the gene, compare cases against controls, and then you just see if there's a gene-based burden association. And this is a very tedious work, because every single gene in the genome, you have to first see through all the variants, then you've got to identify which are the ones that are pathogenic, and then you can make cases against controls. So imagine you could do that across every gene in the whole genome. And so this work that we use this approach, my colleague, Dr. Zheng Li and Wang Zhenqian, they found this, using this approach, they found a gene called CYP39A1 for whole exfoliation syndrome. And this was published a few years ago in JAMA. And so far, this is the approach that we're doing for both open angle glaucoma and angle closure glaucoma. And for angle closure glaucoma, we did whole exome sequencing of more than 5,000 cases from these different countries. as well as 7,000 controls. So these were most of the GWAS populations. We did the same whole exome sequencing. And then we found a new gene called UBOX5 to be strongly associated with ankle closure glaucoma with odds ratio of more than 2. So this work is currently under a revision. And you can see here the whole exome sequencing of the different populations. You can see the odds ratios, and you can see the consistency of the association. Mostly it's on the right, and you can see apart from 1 or 2 populations where it's a very wide confidence interval, most of them are quite strongly associated on the right-hand side. And overall, the odds ratio is about 2.1. Yeah, you can see here. And you can see that some populations are even stronger than others in terms of the association. But of course, it also depends a lot on the sample size. So what is this gene UBOX5? So it is something related to the ubiquitin pathway, which is related to cell waste disposal. And there are other associations with UBOX5, like diabetes insipidus, as well as the immune system. But really, we can't explain what it does in the eye. But if you look at the in the mice, for example, it's expressed in the cornea, in the ciliary process, and the iris, and it's also strongly present in the lens as well, and as well as in the retinal ganglion cells. So it's actually, as ubiquitin means, it's quite everywhere. And here you can see it's particularly strongly associated in the iris sphincter and in the retinal ganglion cells as well. So here, the anterior segment staining in the humans, you can also see the staining in the iris. So we try to work out what it does. We have a UBOX knockout mouse, and then we try to see the phenotype. And so this is the current work. It's unknown what it does, but there seems to be definitely an association with UBOX with ankle closure glaucoma. The last part of my talk is on nanophthalmus, and I think Vinay asked me to talk about nanophthalmus. So nanophthalmus is an eye which is smaller than usual, but anatomically they're quite normal, except they're small. So it is, and there have been different nanophthalmic loci that have been identified. You can see here the different regions, and as well as some of the genes identified from the different locus. So one of them is MFRP. It's a very interesting gene, and TMAM98 as well. And they seem to be, expressed particularly in the RPE, ciliary body. Some of them are present in the sclera as well. And really, it's not that much known in terms of some of the genetic factors here. And we also looked at PRSS56, which is a mutation related to microphthalmia, nanophthalmus, higher hyperopia, PC. So these are like syndromic cases, and it seems to have very severe kind of ankle closure phenotypes. So just a short few words about nanophthalmus. So in summary, we've given an overview of ankle closure genetics, and I said there's some familiar cases, as in, for example, the Moorfields group had 1 gene identified. We've got 8 GWAS signals from 8 GWAS genetic loci, and there seem to be different associations for PSCG versus PSCS. So maybe related to angle configuration, and others will be related to glaucoma progression. One of the GWAS hits is more related with severity, and from whole exome sequencing, we found a gene called UBOX5. So hope we understand more for ankle closure, those of biology as well as for personalized medicine and maybe targets for therapy. I'd like to acknowledge funding sources, as well as my collaborators and group in Singapore, and all the collaborators involved, particularly Professor Wang Yingli in China for the GWAS studies, and all our colleagues in India here from Sankara Nethralaya, Nara Nethralaya, Aravind, and All India Institute of Medical Science, as well as from colleagues from the other parts of Asia and in Europe, as well as in Japan and other countries. So it's a big worldwide consortium, and also like to invite you in Singapore next year for the Asia Pacific Glaucoma Congress to be held with the SABC International Meeting, which will be late July next year. So those who have not been to Singapore, please come to Singapore for this meeting in July next year. Thank you for your attention.
Thank you, sir, for sharing your wonderful work that you've been doing, exhaustive work over the years in PACG genetics. Since Dr. Janie Viggs ma'am is also there, we would like to understand from her, because she's an extensive work in POAG genetics. So how can PACG work be done in a similar fashion, and what do you think you can give for PACG genetics? What are your insights and the way forward, basically? The mic is there. I also invite Dr. Monisha and Dr. Tinong to please share the chair here.
Well, thank you for asking me to comment on this. I think Professor Ong has done an amazing job describing the field for angle closure glaucoma and narrow angle glaucoma, really covering the full spectrum of potentially rare variants with high penetrance causing Mendelian type from nanophthalmos all the way through to those that are complex. I think that one of the limitations of the angle closure genetics landscape currently is that the GWASs have lagged a little bit behind the POAG. So there are, as Dr. Ahn noted, there are not as many loci for angle closure. And so it's a little difficult then to do some of the work like what we've done in POAG, looking at, say, polygenic risk scores in different aspects like that, which might be interesting and predictive in the angle closure field as well. So, that obviously would require further collaborations and more samples collected and larger GWASs to identify additional loci. I do think it's very interesting to think about what the genetic determinants of the glaucoma are in people with narrow angles and angle closure. And is there any contribution of the genes that we have found in POAG, or found in glaucoma, to the development of glaucoma in those with narrow angles? And so one thing that could actually be done with the data as it exists today is to look at the impact of the POAG, polygenic risk score, on the association with glaucoma in angle closure. Because it might be that the sorts of genes that we find in the angle closure GWASs are those genes that influence the configuration of the eye and the development of the normal angle or narrow angle, but the actual development of glaucoma may be related to some of the same genes that we find in open angle glaucoma. So that might be something else to explore.
Yeah. Thank you.
That's an interesting
I think we have one GWAS hit, which is in all forms of glaucoma: angle closure, open angle, and exfoliation. So that's a very interesting hit. Yeah. So it's found in POAG GWAS, angle closure GWAS. But in angle closure, it wasn't significant, but because of the sample size.
So thank you. Please share the chair here. So now we come to the clinical part of our session. Dr. Monisha Nongipur. She has a phenomenal experience in dealing with the angle closure glaucoma, looking at a publication profile of angle closure glaucoma. And she's here to share her wisdom in plateau iris and angle closure glaucoma among the young with us here today.
Thank you, Dr. Vinay and Shikha for inviting me here. So we're going to move from genetics into something more clinical. So plateau iris is an important but often under-recognized condition. Thank you. In angle closure, particularly in young patients. So despite being less commonly discussed than pupillary block mechanisms, plateau iris forms an important mechanism for angle closure, particularly in young patients. So today I will share about I'll talk about its definition, characteristics, and some management approaches. So traditionally, plateau iris is defined on gonioscopy as an occludable angle or closed angle with a flat iris plane and a relatively deep central anterior chamber. So based on the AIGS consensus statement, AIGS is the Association of International Glaucoma Societies. So their consensus statement, they described or categorized angle closure mechanisms based on the forces acting at 4 anatomical levels, where level 1 is at the level of the iris or the pupil, which is pupil block, and plateau iris forms is due to the forces acting at level 2 or the ciliary body. So in addition to plateau iris configuration and plateau iris syndrome, I'll come to the differences in a bit. There's also certain pathological conditions of the ciliary body, such as cyst or ciliary body tumors, that also gives rise to a similar plateau iris configuration. So that's called pseudo-plateau iris. So the hallmark of diagnosis of gonioscopic diagnosis of plateau iris is a double hump sign. So this means when you do a gonioscopy, you see two humps, and this is the curvature of the iris, which follows the first initial elevation you see is which follows the curvature of the iris over the lens up to the periphery, and then it rises up again for the second, like the double hump that you see over the ciliary processes. So gonioscopically, it is not easy unless you look for it or you really look for plateau iris. But there are imaging, it can be identified or diagnosed from imaging. But AIOS2025, like I said, plateau iris is at the level of the ciliary body, and we know AIOS2025 cannot, the resolution below the iris is not very good. So it has much lower penetration than the UBM. So the UBM is the imaging of choice. There have been studies that have looked at the AIOS2025 definition of plateau iris, but the ideal or the perhaps gold standard imaging modality is the UBM. This is the old slide. Okay, I'll probably come back. Okay, this is the UBM features. So because using the UBM, you can see it's important to confirm the presence of the anteriorly directed ciliary processes as well as absent ciliary sulcus. So the reason why you have the plateau iris configuration is because the ciliary process is directed anteriorly, and that pushes the peripheral iris. So that's the angulation that you see. So these are the requirements for the UBM characteristics for diagnosis of plateau iris. And of course, iridotrabecular contact or irido-angle contact is important as well. So you need these 5 characteristics need to be present, fulfilled in at least 2 quadrants in an eye to be classified as having plateau iris. So now I'll go back to, sorry, this was it. So, okay, so that is plateau iris. So plateau iris configuration is when you see a patient before a laser PI. So it's called plateau iris configuration. But the persistence of this configuration, this type of picture that you see, after an LPI, that is what we call plateau iris syndrome. These are features that are similar to plateau iris configuration, except that it is not alleviated by an iridotomy. Or the other definition of plateau iris syndrome is when eyes with a patent iridotomy on dilation, the angle closes and the IOP is elevated. So the 2 types of plateau iris syndrome: complete, this is on gonioscopy; complete or incomplete. Complete is when there's closure up to the shoulder base line, and this usually results in elevated IOP. And incomplete closure is when there is closure but not where a bit of the trabecular meshwork is still seen and the IOP is still normal. So what is important is that for these patients, plateau iris patients who've had laser iridotomy, they need to be periodically monitored gonioscopically to see for early developments of PAS or elevated IOP as well. And pseudoplateau iris, like I mentioned, iridociliary cysts or ciliary body tumors. So I've talked of this. So coming to the epidemiology and risk factors, so studies have found that about 20 to 30% of patients with primary angle closure actually are found to have plateau iris syndrome after laser PI. And some of the risk factors include female gender, hyperopia, younger patients, family history, and also some genetic transmission have been described as well. So in this, this was a paper by Dr. Robert Rich in 2003, where they actually did a chart review of patients' angle closure, all the angle closure patients in their clinic who were less than 40 years old. They found that the prevalence of, or the proportion of plateau iris in these angle closure young angle closure patients was about 52%. And out of these, 17% presented with acute angle closure. And again, similar characteristics, female preponderance, younger group, and also family history of PSEG. And there was an earlier So that was in predominantly Caucasian population, but a more recent paper by Gao et al., where they look at the prevalence of plateau iris in young Asians, younger than 40, they found the proportion was about 25%. This seemed a little less compared to what was described in the Caucasian population. And one of the reasons was that if you, in this paper, these patients, the 25% were specific or purely plateau iris, but they also had about 50% of patients who had a mixed mechanism, including plateau iris in those. So that was not included in this 25%. So overall, it should perhaps be a lot more. So probably perhaps 30 or 40% have plateau iris syndrome. So the goal of treatment in plateau iris is to prevent the development of peripheral anterior synechiae and disease progression. The first line of treatment is laser iridotomy because there's always some component of pupillary block. So if the angle opens, periodic gonioscopy is warranted. And argon laser peripheral iridoplasty is performed if the angle closure persists or if in follow-up the angle closes. And so this is what argon laser does is these are laser shots which are fired to the peripheral iris, resulting in contraction of the peripheral iris and opening up the angles. So these are pictures before and after laser peripheral iridoplasty showing UBM images before and after and slit lamp imaging, showing opening of the angles. So there was a study which showed that there was persistent opening of the angles following just one treatment, single treatment of laser iridoplasty in about 2/3 of patients with plateau iris. And the other treatment modality that has been described for some of these patients is endoscopic cycloplasty during lens extraction, where laser, which results in shrinkage of the ciliary body processes and helps to further widen the angle. So this was a paper where we looked at the proportion of plateau iris across different disease severity. These were not in young patients. These were older patients with PSEG. And what we found was that there was a significantly greater proportion of plateau iris in patients with severe PSEG. And interestingly, these patients with severe PSEG not only had a greater proportion of plateau iris, they also had a younger age of onset of PSEG, higher presenting IOP, and a greater extent of peripheral anterior synechiae. So this finding suggests that plateau iris may be a contributor for disease severity, and the younger age of onset could be one of perhaps two reasons. Either they developed severe disease earlier, or they underwent rapid disease progression. So in summary, plateau iris is an important and often under-recognized condition, particularly in young. And diagnosis requires gonioscopy, which, like I said, it's not easy, but imaging, UBM imaging modality gives a more definite diagnosis of plateau iris, or an objective diagnosis. And sometimes, especially in young patients, LPI alone is not sufficient. And periodic gonioscopy and early detection of worsening closure and also elevated IOP is crucial to prevent development of PAS and prevent disease progression. I'd like to acknowledge my fellow, Shimna, for helping me with some of the slides. Thank you very much.
Thank you, Dr. Monisha. That was an excellent insight into plateau iris. So is it a routine that you do UBM for all your patients?
No, unfortunately
Yes.
we don't. So that was just a study. These were patients that we had recruited as part of our research, but we don't.
So
and
can
I
you
think
give us some take-home pearls, because not everyone has access to UBM also, how to diagnose these patients maybe on
gonioscopy. I mean, I think we need to
AIOS.
really we need to perhaps perform gonioscopy for all patients. The more you do, the easier you become. And if you don't look for it, honestly, you'll not find plateau iris, So you've got to look for it, look for the double hum sign. Not always easy, but it's definitely seen. And also gonioscopy after doing an LPI. Sometimes we don't repeat gonioscopy, so that's really important as well.
So anybody who wants to ask a question on this? So incidentally, we've also stopped doing laser PI for our younger patients. which we know are plateau iris, because they usually are not responding, and if the pressure is not getting controlled with medications.
So what you do, iridoplasty first as a
because
first
we have done LPI for like 100, 150 patients, and it really doesn't.
But I think in younger patients, LPI perhaps may not work very well because the pupillary block component wouldn't have developed by then. So usually you see that after the age of 40. In young patients, pupillary coexisting pupillary block is not. So the reason we do LPI in adults is because there's always a component of pupillary block, and that itself, because without LPI, you cannot differentiate what is the component of plateau iris and the component, the angle closure component of pupil block. So sometimes with just, they may have a plateau iris configuration, fulfill all the features except that the angle is open. So that is because of the pupil block component. So they have all the, you know, the flat iris plane, the angulation, anteriorly directed ciliary processes. But in these patients, the IOP usually does not go up, but you need to monitor them as well.
And another difference that we have found is in our plateau iris population, we don't really see the peripheral anterior signing K. The angle is occludable, stays occludable. We don't want alarms, please. We have plenty of time with us. So what we see is occludable angle, even if they are severe glaucoma, end-stage glaucoma, and we're taking them for surgery, for MIGS along with, you know, cataract lens extraction. So the angles remain open till the end.
You're talking young or older?
Young.
Yeah. So I think because I guess one of the reasons is because PAS again takes time to develop, and once you've done an iridoplasty, you're actually reducing the risk of your angles already open, even whether it's a PI or that apposition is already, you know, you're decreasing that apposition, and so that could be one of the reasons, and that's why iridoplasty is probably warranted if the angles are very close, complete plateau iris syndrome as well, because persistent apposition, friction, that is going to cause PAS as well. So I'd like to introduce Shikha for our next talk.
Thank you. The last speaker is Dr. Shikha Gupta, and she speaks on management options and outcomes of angle closure glaucoma in the young.
So I welcome everyone, and we didn't have our two speakers who were to talk about the characteristics of early onset angle closure glaucoma, so I will try to cover a little bit that is there in my slides. So is early onset angle closure glaucoma different from late onset? So we have been seeing the patients in the two categories lately, and we realize that they are two different entities altogether. They have to be diagnosed separately, and they have to be dealt with, managed in a different manner altogether. And why do we need to worry about the management part? Yes, because the management differs. Just like we heard that LPI may not work in early onset glaucoma patients, similarly the other part of the management also differs. And should we think differently when we see these patients? So first time the angle closure glaucoma in the young was reported by Rich et al. In 2003, where he, you know, took a heterogeneous population which included younger patients, less than 40 years is the definition, and included patients of uveitis, ROP, and microspherophakia also. So that was a heterogeneous cohort. So we were seeing a lot of these patients, so we started collecting the data. Now we have 250 plus early onset angle closure glaucoma, which we are compiling data, genetics, and the management strategies. So what is different in these patients is the etiopathomechanisms. So they have more of plateau iris compared to pupillary block mechanisms in late onset glaucomas. Also, they have higher risk of complications if we want to take them for trabeculectomy. They are advanced glaucoma and the pressure is not getting controlled. So compared to late onset PACG, we need to think twice, because we know that plateau iris is a predominating risk factor for malignant glaucoma. So these eyes are precarious and they have a higher tendency to go into malignant glaucoma. So we have to really look at the diagnosis properly and plan management accordingly. Now coming to lens extraction. So these patients are early onset, they have good accommodation, and they have clear lenses. So again, we have to think that if we're not planning to do a trabeculectomy or a filtering surgery, should we be planning lens extraction? So let's see. So the definition is there are more than 18 years and less than 40 years in age, and we call them angle closure glaucoma when they have signs of optic neuropathy, either on the fundus photography or pre-perimetric stress or in the perimetry. So, and we plan surgery for them when target IOP is not achieved. So, irrespective of the lens status, whether they have cataract or they are clear lenses, we have to plan surgery for them. So, this is a study which we conducted, and it's accepted, should be out in a month or two. So this is a cohort of 130 patients in each group. So early onset had 130 patients and late onset had 130 patients. So what we see is lens thickness. When we compared the lens thickness between the two groups, between the early onset and the late onset, we saw that the lens is thinner in these patients. So it is going against lens extraction. However, the lens vault was significantly higher in these early onset patients, which was surprising to us. The anterior chamber depth was almost similar with no significant difference. The anterior chamber area was smaller, and the relative lens position, which became an important factor as we analyzed the data, the lenses were thinner and were anteriorly placed compared to the late onset glaucoma. Despite being thinner, they were causing more crowding of the anterior chamber. So as we discussed that this is already a known fact that these patients have non-pupillary block mechanisms like plateau iris, which was significantly different. And we could see that the combination of plateau iris and pseudoplateau iris is the presence of ciliary body cyst leading to a plateau iris kind of configuration, which was almost like 40% of the eyes had ciliary body cyst kind of presentation, which was again significant compared to the late onset eyes. So they are different, definitely. And that is why Dr. Manisha also talked about endocycloplasty. We're dealing with the laser photocoagulation of the cysts which are present in the ciliary body. So this we can see that this is a plateau iris configuration where the ciliary body is almost opposed to the back of the iris, and these are the different cysts that we see in these patients. So this A is early onset biometry AIOS picture, and this is the late onset AIOS picture. So this is evident from the fact we can see that this is a plateau iris kind of a configuration compared to this relative pupillary block here. We can see how thin the lens is in this picture compared to the thick lens placed here. Then also the ACT is shallower in early onset glaucoma compared to a deeper AC in late onset. And we can see how high the LV is compared to this LV. So though we know that the lens is thinner, so lens thickness is not the only parameter that we should be seeing on IOL master. We should also request for a lens vault as well as a relative lens position before we decide on what is the management strategy for these patients, which has to be individualized. So when we made the scatter plots, we found this is the age. So these are younger patients on the left side of the graph, and the older patients on the right side, that they had smaller axial length, which was significantly different. They had more anterior relative position, again significantly different. The lens was thinner, and the lens vault was again higher in these patients. So when we looked at the cutoff, it was found that a lens thickness which was less than 4.5 was significantly associated with EOPACG, development of early onset glaucoma compared to late onset, and the lens position had to be again 0.7 was the cutoff for the relative anterior lens position for EOPACG. The axial length had to be smaller than 22.7, so they were smaller axial lengths but not nanophthalmos, they were excluded in the study, and the lens vault was higher than 650. That was the cutoffs that we obtained with the 0.59 cutoff here. So then we analyzed our data of eyes which were, it was a ambispective study where we included our retrospective patients and we included some prospective patients also. So of the 50 patients that actually underwent surgery, 25 of them underwent trabeculectomy and 25 underwent phaco with MIGS, some sort, either GAT or nasal goniotomy, and then we collected data pre and post. So 12 months was the last follow-up that we did. And the primary outcome measure was the reduction in IOP from the overall baseline, and the secondary outcome was complications and the number of medications that was decreased after the surgery. And the success was determined on the target IOP, which was set at 18 millimeters for the moderate glaucoma eyes and 15 millimeter mercury for the advanced glaucoma eyes. And the failure to achieve the target IOP or need for a surgery was considered a failure. So of the two groups, we could see that the pre-operative data was almost similar with similar mean IOP score, although there was a little bias towards a more severe glaucoma in the trabeculectomy group. So what we saw was the IOP reduction was almost similar in the two groups. This is the phaco with MIGS group, this is the trabeculectomy group. So it was almost similar. The medication reduction was almost similar in the two groups. And this is over the different subjects that we saw, that this is the pre-op, blue is the pre-op in trabeculectomy and red is the post-op in trabeculectomy, whereas in MIGS it was, blue is the pre-op and purple is the, so the IOP profile was almost similar in the two groups. So we can see that the pre-op IOP was lying between 30 to 40 millimeter mercury in both the groups, and post-operatively also it was able to achieve the target IOP. So we could see that 84% eyes achieved success in phacoemulsification with MIGS group compared to 72%. And the absolute success rate was also non-significant, although it was more with the trabeculectomy group, but it was not coming as significant because of the small sample size. And even in the severe glaucoma, both the groups achieved almost similar success. However, the number of complications was 12% in the phaco-MIGS group compared to 24% in the trabeculectomy group, which was again insignificant because of the small sample size. So these are some AIOS pictures that we reviewed, and we could see that this is the pre-phaco-MIGS group. This eye underwent nasal goniotomy, and we can see the cleft here. And we can see how deep the anterior chamber becomes after the clear lens extraction with a goniotomy. Compared to this is a pre-trab group in, again, a patient with EOP ACG. And post-trab, we have shallowed the AC further. And this patient is, of course, going to require a cataract surgery eventually. So if we counsel the patients well that we are going to do a clear lens extraction which may be indicated for you, and accommodation problem could be there in early glaucoma or moderate glaucoma, we can also go for premium IOLs to help him with the accommodation. It should not be a challenge. So this was an ICG angiography picture that we did in a pre and post GAT in an EOP ACG patient. This is pre doing the MIGS surgery, and we can see the aqueous channels were of course formed, but post GAT we can see how well developed they are. So this is of course more physiological also than trabeculectomy. So the complications that we saw in the phaco goniotomy group was 3 eyes had hyphema, and all of them were self-resolving. And 1 eye also had self-resolving vitreous hemorrhage, which can sometimes happen when we are doing phacoemulsification alongside, and the aqueous percolates down through the sulcus. So in the trab group, 1 eye developed malignant glaucoma, which was managed. 3 eyes had bleb leak, which was again managed conservatively. And 2 eyes had hypotony, which was self-resolving. So these are different challenges with trabeculectomy. We are still trying to titrate our trabeculectomy outcomes every day. So phacoemulsification with MIGS was found to be non-inferior to trabeculectomy in terms of IOP control as well as the need for medications in patients with EOP ACG. The absolute success was though more in the trabeculectomy group, but it was not clinically significant. But phacoemulsification with MIGS had fewer complications which were more conservatively managed. And therefore, one should, decide on after diagnosing the patient well, what is the best in his skill set, what is the best for the patient after taking consent and titrating the pros and cons of each procedure. But phaco-MIGS does help in lowering the IOP in an almost consistently similar fashion as trabeculectomy. So this was a study which was just come up in angle closure glaucoma of the young, where they have also compared outcomes of filtering surgery versus clear lens extraction. And they also found that the efficacy of clear lens extraction, this is an American journal which has just been published, that the efficacy of clear lens extraction was comparable to that of filtering surgery in medically uncontrolled ACG patients of the young. But clear lens extraction was found to be safer than trabeculectomy. And this is in late onset glaucoma group, where they did a trial on 50 eyes between phaco or trabeculectomy, and they found again that after 2 years, both phacoemulsification and trabeculectomy were equally effective in reducing IOP, but trabeculectomy was more effective in reducing dependence, but again it was associated with more complications, a result which is consistently seen across the world. So in our study, the sample size was small and a short duration of follow-up. But we can, of course, the results that we see, they encourage us to do a longer study in these patients. Thank you. Any questions, I welcome.
Thank you. I have a question about the analysis of your cases, young versus old. Because you only have 132, maybe, if you lump them all together and look at means, you may not really see some differences within subgroups.
Yeah, we have just done a preliminary analysis right now. We have not yet written it down for publication, the management strategy.
Yeah, because I think we found that even in the old, there's a group who are pluthoiris and the groups which are predominantly lens, and then there are others. So, but, and probably in the young, you may have a different mix, but it's the problem is in the old group, because you lump them all together and then you do the analysis, you miss out the subgroups within the old.
Within the group?
The old group.
Okay. Yeah. I am not able to really understand what we need to derive.
Oh, because in the old group, you are assuming they're all the same. So when you did the analysis, you put all the young together and you put all the old together. Yeah, but within the old, there must be some which have plateau iris as well. And so when you missed it, because you are put them all together. So I think you need to think about how to analyze the old group. The young group is, I think, perhaps, you looks like it's much more plateau, but predominantly plateau, but even then the lens vault seems to be very high, which is very surprising. So I'm not sure if it's just purely plateau. It could be also some lens mechanism as well.
There was no ciliary effusion. We had ruled them out. So there was no other secondary causes.
No, but the lens vault was very high. It was quite surprising.
It was not so high. It was like 750 microns range. So it was not like in age-related cataract when we know that the lens vault becomes high and leads to. So it was not more than 1,000 microns. So, but it was higher than the late onset group.
Right.
Yeah.
Lens vault and lens thickness. So we've done a study where we actually found that the lens vault is actually independent of the lens thickness in angle closure patients, because you may have a thin lens and you can have angle closure, but the lens vault is high. So we divided it. So the lens vault in normals, which had the same lens thickness as normals, and lens thickness which is greater than in normals. So in the ones where the lens thickness is similar, the lens vault was actually bigger in angle closure.
So there's
patients.
a concept of long anterior zonules which is coming up now.
Yes.
So I believe that maybe that we have not really seen that, because
this is what we saw in older people. So
Yes.
these are older onset PSEG, which may be it's a smaller proportion in older, but maybe a predominant proportion in younger patients. This is probably what we
So
see.
maybe if we look at long anterior zonules, these patients might turn up to have a higher proportion of longer anterior zonules, which leads to higher lens vault.
Yeah, so it's
in
just
these
that the
eyes.
lens is more anterior. So the lens vault is the proportion of lens of the proportion of the lens that is in front of the angle. So you may have a thin lens, but if it's a higher proportion of it is in front of the angles, your vault is higher.
Yeah.
So that's why lens vault is a better indicator of the role of the lens in angle closure than lens thickness on its own.
Yeah.
And so quick question. So for I saw your pre-op IOP was about 40 in both the groups, and so what were they? They did not respond to any medication. Did they have?
So this was baseline IOP. This is untreated IOP.
Untreated. All
This
right,
is not
okay.
the
This is not
treated
the
IOP. This is the baseline IOP that we consider to just look at the severity.
And so, but because it was written pre-surgery IOP, so
because these are all taken for surgery, so that also indicates that these were the severe eyes of the patients of PACG that really required surgery had actually higher baseline IOPs than the other patients who were controlled on medical therapy.
and they did not undergo surgery.
No.
Okay.
So this is the group that have
That had
undergone
higher.
surgery.
And did in how many? What's the proportion of iridoplasty in them?
So we actually do not do iridoplasty in all our patients,
Even plateau iris.
even plateau iris, yeah.
Any reason?
So we did PI, and that also helps in opening up the angle. So when it doesn't really help, and the patient does require surgery, and we know that the lens
straight.
vault is higher, we then take him for the surgery. Yeah.
And again, it's just important.
So
to know-
how has your experience been for iridoplasty? For those requiring surgery, so how many are able to shelf off the surgery with the help of iridoplasty alone?
So, because I think the ones under 40 are in the pediatric clinic.
Okay.
They are in the adult clinic, but
For plateau iris in the older
in
age
the
group
old
also.
we don't usually do, unless of course the lens is still. The
We
younger
did
ones,
for few of
between
our
40 and
patients in the
50.
beginning when we started doing this, and we did not have a very good response. So we're not doing it routinely for our eyes.
So if they're, the cataract is not very, they still have, relatively clear lens, good vision, and pressure is high, closed angles, we do see a slight drop in the IOP with iridoplasty.
Yeah.
But yeah, I guess but with cataract, with concomitant cataract, then of course lens extraction is.
Ours are usually,
by the time they
lenses.
come.
Yeah.
Then the other thing to remember, I think that there was a paper published quite some time back on looking at the persistence of plateau iris even after cataract extraction, because plateau iris, it's because of the ciliary body. So even if you remove the lens, the angles can still be closed. So
That's
can
where the
happen.
MIGS is helping us.
Right.
So what it does is when we, cleave the trabecular meshwork, it
Having
just falls
an
back,
alternate opening.
and everything falls back with that. So you saw how open the angle becomes. So this has been our usual experience that the plateau iris doesn't really, hamper. Although some eyes do fail. We have 3-4 eyes which have failed with MIGS also.
Then they've gone on to
require trabeculectomy eventually, but the factors for that are yet to be analyzed.
Okay.
And
That'll be good to look at whether the angle
Exactly.
closure is persistent or
Yes.
not, even after cataract extraction.
yes, thank you.
Thank you. We'd like to welcome questions from the audience.
So we did do iridoplasty in 5 or 6 of our patients in the beginning, and in our experience they didn't work. Because we know that the lens is lens is causing the high lens vault. So we have the reason there that even if you flatten the iris in the periphery, the lens is still there with the high lens vault. That will still remain. So since we did not get a good outcome, and iridoplasty outcomes are equivocal. If you look at the text, they are not that effective as your surgical measures. So we being in a government center, we really don't take that pain then to take every patient for iridoplasty before taking them for surgery. So it's your call, and you can of course form your own experience about iridoplasty in these eyes.
The question is about there is any Indian study on iridoplasty?
I don't know. I don't think so. Yeah. So any other audience questions? So we can conclude the session if there are none. Thank you audience for coming and listening to the talk. And this area is new, and we are also in the learning phase. And I hope we are able to shed more light on this topic in the years to come. Thank you so much. So we can have the speakers for the photograph before we conclude this session.
Apologies, but the last 2 speakers didn't turn up.
Picture.
But Vinay is not there.